Stroke is a leading cause of long-term disability worldwide, often leaving survivors with significant challenges in regaining movement and sensation, especially in their arms and hands. Rehabilitation is crucial for helping these individuals recover as much function as possible. In recent years, researchers have been exploring new ways to enhance traditional therapies, aiming to improve both motor and sensory outcomes. Today, we'll take a closer look at an innovative clinical trial that combines two promising approaches: modified constraint-induced movement therapy and sensory threshold somatosensory electrical stimulation, to see how they might work together to help stroke survivors regain independence. After a stroke, many people experience difficulties with movement and sensation in one side of their body. This can make everyday tasks like buttoning a shirt or holding a cup extremely challenging. Sensory dysfunction, such as reduced touch or proprioception, is common and can further limit recovery. Less than half of stroke survivors regain full use of their affected hand. Improving both motor and sensory functions is essential for better quality of life and greater independence. That's why researchers are constantly seeking new methods to address these complex challenges. Constraint-induced movement therapy, or CIMT, is a well-established rehabilitation approach designed to help stroke survivors use their affected limb more often. The basic idea is to restrict the use of the unaffected arm, forcing the person to rely on their weaker side during daily activities. This intensive, task-oriented training encourages the brain to reorganize and adapt, leading to improved motor function. However, the original CIMT protocol can be exhausting, requiring long hours of therapy each day, which sometimes leads to poor compliance. Make CIMT more accessible and less tiring, therapists developed a modified version called MCMT. This approach shortens the treatment sessions and reduces the amount of time the unaffected arm is restrained. Despite these adjustments, MCMT remains highly effective in promoting motor recovery after stroke. It focuses on intensive, repetitive practice of meaningful tasks, helping patients gradually regain control and confidence in their affected arm. Sensory threshold somatosensory electrical stimulation, or SENSES, is another promising technique in stroke rehabilitation. It involves applying mild electrical currents to the skin, just enough to create a tingling sensation without causing muscle contractions. This type of stimulation can enhance sensory function and promote changes in the brain's motor cortex, potentially leading to better movement and sensation. Researchers believe that combining SENSES with task-oriented training could further boost recovery. In this clinical trial, researchers recruited 48 stroke survivors and randomly assigned them to 3 groups. One group received both SENSES and MCMT, another received only MCMT, and the third group received conventional physiotherapy. All participants attended therapy sessions 3 times a week for 4 weeks. The study was carefully designed to ensure fairness, with randomization and blinding of key personnel to minimize bias. This rigorous approach helps ensure that the results are reliable and meaningful. Participants in the study were adults aged 35 to 80 who had experienced their first stroke within the past 2 years. They needed to have some ability to move their affected hand and meet specific cognitive and physical criteria. After screening, 48 participants were divided equally among the 3 groups. This careful selection ensured that the study results would be relevant to a broad range of stroke survivors, while also maintaining safety and consistency. Each group followed a specific therapy plan. The SENSES plus MCMT group received both electrical stimulation and modified constraint-induced movement therapy during each session, while the MCMT group received only the modified therapy. The control group participated in standard physiotherapy. All sessions were supervised by trained therapists, and participants were encouraged to use their affected arm during daily activities, tracking their progress in home diaries. This structured approach helped maximize the benefits of each intervention. To evaluate the effectiveness of each therapy, researchers used several standardized tests. Sensory function was assessed with the SEMS, Weinstein Monoformance test, which measures touch sensation in the hand and arm. Motor performance was evaluated using the Wolf Motor Function test and the Motor Activity Log, both of which assess how well participants could use their affected arm in daily tasks. Muscle tone and stiffness were measured with a specialized device called the Martin PRO system. These objective measures provided a comprehensive picture of each participant's progress. Results were striking. Only the group that received both SENSES and MCMT showed significant improvements in sensory function of the upper extremity. These participants experienced better touch sensation in their hand, forearm, arm, and shoulder, compared to those who received only MCMT or conventional therapy. This suggests that adding sensory electrical stimulation to movement therapy can provide unique benefits for sensory recovery after stroke. When it came to motor function, both the SENSES plus MCMT and MCMT groups showed significant improvements compared to the control group. However, there was no significant difference between the 2 intervention groups in terms of motor performance. This means that while both therapies helped participants use their affected arm more effectively, adding sensory stimulation did not provide additional motor benefits beyond what was achieved with MCMT alone. The study also looked at changes in muscle tone and stiffness, which are common issues after stroke. The SENSES plus MCMT group showed a significant decrease in tone and stiffness of the distal muscles, those farther from the body, like the wrist and fingers, compared to the other groups. However, there was no significant difference in the proximal muscles, such as the upper arm and shoulder, between the 2 intervention groups. This highlights the potential of combined therapy to target specific muscle groups more effectively. Participants were asked to wear a constraining mitt for 5 hours daily outside of therapy sessions. In reality, the average usage was about 3 hours per day in both intervention groups, resulting in a success rate of around 65%. This is consistent with previous research, which shows that longer therapy sessions can lead to fatigue and low adherence. By keeping sessions manageable, the study achieved good participation and reliable results. While the study's findings are promising, there are some limitations to consider. The sample size was moderate, and there was no long-term follow-up to assess whether the benefits were sustained. Most participants were in a phase of spontaneous recovery, which could have influenced the results. Future research should include larger groups, longer follow-up periods, and explore different stimulation parameters to determine the optimal approach for maximizing recovery after stroke. In summary, this clinical trial demonstrates that combining sensory threshold somatosensory electrical stimulation with modified constraint-induced movement therapy can significantly improve sensory function and reduce muscle stiffness in the affected limbs of stroke survivors. While both therapies are effective for motor recovery, the addition of sensory stimulation offers unique benefits for sensation and distal muscle tone. These findings contribute valuable insights to the field of neurorehabilitation and offer hope for more effective, personalized stroke recovery programs in the future.